Okay, good evening or good day, depending on where you're joining us from. I'd like to welcome you to the prostate cancer biopsies debate. I'm Joe Gallo from ANCAN, and I just want to do a couple quick administrative points, and then we'll get right into the discussion. Please make sure that your webcams and microphones are off. Okay, anybody who comes in, but that will only distract from the presentation. Okay, your questions may be entered at any time, including during the presentations. They won't be addressed until the end of the discussions, but you can put them into the box that's called questions, and the moderators will manage those. And that should do it. I'd like to then introduce our leader of ANCAN, our founder, Rick Davis.
Good evening, everybody. This is an exciting evening. It's the culmination of a huge amount of effort from Howard Walensky, who many years ago took it on himself to educate the dirty unwashed out there about two things: active surveillance and transperineal biopsies. And he's been immensely successful. And we promised to have this debate last year, and we didn't have space, and so the debate is now this year. And we welcome Doctors George Arvin and Deborah Kaye from Michigan and Duke, respectively, two institutions that are very fine genitourinary institutions. I'm Rick Davis, you probably figured that out, and we at ANCAN now run 25 groups or 26 groups a month for 14 different conditions, but we started with prostate cancer. That is really our mother lode. We have 11 meetings a month for prostate cancer, and we're very proud really to be the leader in the virtual support field, which we've been running now since 2010, long before anybody heard of COVID. So please check out our website, ancan.org. We do a lot more than prostate cancer. We work with other cancers like pancreatic and thyroid. We work with multiple sclerosis. We have some fantastic mental health programming, some great mental health arts programming. Tomorrow night we've got a virtual art class going on, and we do it all with your support, and we thank you very much. So I am very eager to see who's going to shift opinion the most, and with that I will turn it over to the eminent, indisputable king of active surveillance, Mr. Howard Walensky.
Well, thanks, Rick. First off, we should say that we're not offering medical advice today, so don't even think about it. We may come to the edge of that, but we're trying not to offer any advice. Any rate, welcome to everyone. Welcome to those of you who are regulars. And this evening, I think we are having a number of new people. So we want to welcome you all. And so, as Rick alluded, transrectal biopsies and transperineal biopsies have been the subject of debate for urologists and patients alike for the past few years. And yeah, I made it part of my personal agenda. I'm a person who's had 6 transrectals, so I know part of the game here. I don't know the other half, but we're going to learn about that tonight. It's indisputable, as Rick says, men on active surveillance for prostate cancer are not big fans of biopsies to begin with. But on the other hand, biopsies can be essential for our care. And our speakers tonight are taking positions on 2 types of biopsies. Dr. Deborah Kaye is an assistant professor of surgery Division of Urology, Duke University Medical Center, and Duke Cancer Institute. She will be presenting the pro-transperineal biopsy argument. Dr. Arvin George is an assistant professor of urology at the University of Michigan, go Blue, specializing in the diagnosis and management of genitourinary cancers. Yes, I do have a Michigan credential. Each debater will, but I'm not prejudiced. This is going to be even-handed. Each debater will have approximately 20 minutes to make their case. Then they will cross-examine each other for about 15, 20 minutes till they run out of gas. Finally, we will open up to questions. So please submit your questions to the chat box. Talking about questions, before the debate begins, we will be running a poll on where the audience stands on transrectal versus transperineal biopsies. We'll poll you now, and we'll poll you again before the questions and answer sessions. So let's take a minute to answer the poll. Joe? Okay.
This is Rick, and
Still
I
in
do
progress.
one thing. So whilst you're answering the poll, I'm just going to say that we do need to express our thanks to our sponsors tonight that include Bayer, Janssen, Pfizer, Foundation Medicine, and I think I'm missing somebody. Alexa, you can come in and help me with whoever I forgot. I think there should be one more.
Of course, we absolutely want to thank Pfizer, Bayer, Advanced Accelerator Applications, a Novartis company, Foundation Medicine,
Novartis, thank you.
Janssen, and of course, we want to thank our nonprofit sponsors, the Active Surveiller, Prostate Cancer Support Canada, ASPE, and the Prostate Cancer Forum of Orange County, California. Thank you so much.
Thank you, thank you, thank you, thank you.
So, okay, in terms of the actual winner, in terms of the type of biopsy, we've had 69% have had transrectal, 7% have had transperineal, 9% have had both, 10% have had none, and 5% just aren't sure. And if we had the time, I think we could wheedle it out of you. But the polls are closed, and we're going to see how opinions go after that. So now we'll move on to Dr. Kaye. It's approximately 8:15. So Dr. Kaye, you have the floor.
Great, thank you. Just have to share my screen. Okay.
There we go.
Can you see me okay? Can everyone see okay?
It's on there, yes.
Great, great. So thanks so much for having me. I'm so excited to be here and to join the group for this evening and present the topic of prostate cancer biopsies, the great debate. Just one disclosure, I am a consultant for J&J Pharmaceuticals. And so as has already been described, we're gonna debate if the TRUST biopsy or transrectal biopsy versus the transperineal or the TP biopsy approach. And I'm going to be arguing that the TRUST biopsy should be the standard of care. And you know, I know that you're going to be with me at the end of this presentation. So just a brief outline. I'm just going to give a quick outline of what the prostate gland is and prostate biopsies. And then we're going to say why TRUS. Why is it important to do the TRUS biopsy? And we're going to talk about cost, safety, outcomes, efficiency, and patient experience. Sorry, one second here. I'm just having some technical difficulties. I apologize. Okay, sorry. Okay, so the prostate gland is part of the male reproductive system, and that includes the penis, the prostate, the seminal vesicles, and testicles. And the prostate is a small gland. It's about the size of a walnut that's located just below the bladder and in front of the rectum, which is the area that people poop from. And basically, with age, it often increases in size, and it also has other changes that are not associated with prostate cancer, but the gland can get prostate cancer. And so here's where the prostate biopsy comes in. And the prostate biopsy is to determine if one has prostate cancer and/or if the cancer has progressed. And during the prostate biopsy, the doctor removes a piece of tissue from the prostate. And this is often performed in response to an elevated PSA, which is a blood test that screens for prostate cancer, but the PSA can also be elevated just with an enlarged prostate, or if a patient has an abnormal rectal exam. And it can also be done routinely in surveillance if a patient's on active surveillance. And so here's a picture of the transrectal versus the transperineal biopsy approach. And basically, the transrectal approach, there's the ultrasound probe, which is placed in the rectum, and then the needle goes through the ultrasound probe into the prostate in order to get the tissue for the prostate biopsy. Similarly, in transperineal biopsies, the ultrasound probe is placed in the rectum, but different from the transrectal biopsy. Instead of the needle going through the ultrasound probe, there's another needle probe that's placed in the perineum, which is the area just below the scrotum and just above the rectum. And so now, as I said, we're going to talk about why TRUS biopsy is the gold standard and why it should continue to be the gold standard. And basically, TRUS is fast, it's easy, it's effective, and it's safe. So first, just to start, we'll start about costs. And basically, transperineal is much more expensive than transrectal biopsies. There are several studies in this area, but a study by Altuck and colleagues compared the comprehensive cost of a random sample of about 20 to 30 cases from different biopsy modalities and determined that the transperineal was much more expensive than TRUS. And Roberts and colleagues performed a similar study. It was a consecutive cohort study, meaning they followed patients over time over an 11-year period, and that they also found that costs were significantly higher for the transperineal group. In another study, Mian et al., they found really a minimal reduction in complications, but a huge increased burden in resource utilization. And so why are the transperineal biopsies so much more expensive than the transrectal biopsies? There are a lot of different reasons. The one is capital costs. So it costs money to get the probe that works with the machine, to get stirrups for the patient. The patient has to be up in stirrups. So if you can imagine, instead of, lying like a baby sleeping on the side, someone's legs have to be up in the air. There's disposables such as anesthetic. More anesthetic is required for transperineal versus transrectal. There are needle guides. The disposable needle guides are really expensive. Transperineal biopsies take longer, so they're increased time. They require specialized staff. they often require dedicated procedure suites and the ability to perform IV sedation. And then for patients, because of all this extra time and potential different location for the biopsy to take place, and potentially that they require, sedation for the procedure rather than just local anesthetic, increased time off of work. So they're just so much more expensive on so many different levels. So next we're gonna go to safety. And my opponent is likely gonna argue that infection rates are so much lower with transperineal biopsies over transrectal, but it's just simply not the case. So, old transrectal biopsy techniques, yes, infection rates were fairly high, between 5 to 6%. But now current transrectal biopsy techniques should limit infections to less than 1%. And in fact, some series demonstrate infection rates of 0 to 0.1% using techniques such as augmented prophylaxis and needle disinfection. And in fact, data from my opponent's own institution demonstrate post-infectious hospitalizations of 0.63%, so very, very small. So there is a lot of data to suggest that infection rates are incredibly low now with new techniques in the transrectal approach. So what are these TRUCE biopsy techniques to help prevent infections? Well, they're pretty straightforward, and they really are the basics that most of us in urology use today. So for antibiotics, we use antibiograms, we use augmented prophylaxis and targeted prophylaxis, where we use rectal swabs to help see if there's any resistance or what type of antibiotics we should use. And then for procedural, we use enemas and needle disinfection. And there are studies that really demonstrate no differences, so absolutely no differences in infection rates between transperineal and transrectal. So once again, my opponent's gonna go probably stress all the differences in the infection rates between the two techniques, but it just simply isn't true based on the data. Further, out of Dr. George's own presentation that he gave for our annual meeting in 2021, he reported more non-infectious hospitalizations with transperineal biopsy. And some of these are hematuria or syncopal episodes. So a patient can pass out because they have required greater amount of anesthetic or more painful anesthetic. And there are many, many other studies that demonstrate no differences in other safety outcomes, such as 30-day ER visits, urinary retention. In fact, some studies demonstrate that transperineal biopsies have higher rates of urinary retention, and hematuria, which is blood in the urine. So now let's go to outcomes. And data demonstrates equivalent cancer detection rates. So there are absolutely no differences in cancer detection, and that's with straight ultrasound guided biopsies, as well as with fusion biopsies, where we now fuse MRI images with ultrasound to sometimes get better pictures. In fact, some studies even demonstrate higher cancer detection rates with TRUST biopsy. This one study by Haran colleagues demonstrated 48% cancer detection rate with TRUST versus 42% with transperineal. And then my opponent is also probably going to argue that transperineal biopsies are better for antibiotic management. Basically, that transperineal biopsies use fewer antibiotics than transrectal biopsies. But unfortunately, that's just simply incorrect. And antibiotics are still being used regularly for transperineal biopsies. So there is a theoretical benefit, but we know that it hasn't been met yet. So now we'll go to efficiency. So we know that TRUST biopsy is just simply efficient. It's fast. The average time for a TRUST ultrasound is about 8 minutes. It can be done entirely in the office setting, including fusions, where we fuse those MRI images with the ultrasound images. And there's a really fast learning curve. So fewer patients have suboptimal procedures or procedures where they may not get adequate pathology tissue, and the patient may have to undergo another procedure. In fact, another study by Go and colleagues in a randomized controlled trial, which in our scientific evidence is the best kind of data, they found that transperineal biopsies take longer than TRUST biopsy, and they have higher rates of additional anesthesia. And so what does that mean? That just means more, discomfort to the patient, more time off work, and just kind of worse patient experience. So the question really is do you really want you and or your loved one undergoing an uncomfortable biopsy for an extended period of time using the transperineal technique when it can be done safely, efficiently, effectively, and more comfortable with truss? And lastly, and another thing is transperineal is not generalizable to most practices. So frequently, clinicians will use sedation, such as nitrous oxide. They frequently need clinic OR suites that aren't really readily available in many practices across the country, and also require specialized staff. And so once again, for the same result, a patient has to be more inconvenienced, go somewhere other than the typical doctor's office, undergo risks of anesthesia and or sedation, and take off more time from work with the transperineal biopsy approach. So now what about the patient experience? Well, this is where it gets really bad. So pain scores are double for transperineal than for truss biopsy. So in a prospective randomized controlled trial, once again, the highest level of scientific evidence of transperineal and truss prostate biopsies in 339 patients, Go and colleagues determined that the pain scores were double in patients who underwent a transperineal prostate biopsy compared to those undergoing a truss biopsy. And this finding has been confirmed in other studies, including meta-analyses where we compare multiple different studies. And the increased pain is frequently secondary positioning discomfort, as well as anesthetic administration. And anesthetic has to be in a location that's much more painful rather than in an area that's fairly, where there's fairly little sensation. And there are also higher rates of repeat biopsy. And so this comfort is hugely important for both good patient care at the time of the biopsy, but also for anyone who's undergoing active surveillance, because the key for active surveillance is to stay on active surveillance. And if biopsies are just miserable to undergo, it's going to be a lot harder to keep patients on active surveillance, which overall in the long term likely improves their long-term quality of life. So once again, I mentioned this before, but truss is faster. And so once again, this Go and colleagues, they reported that the truss biopsy was significantly faster than transperineal biopsies. And a study by Kravich and colleagues demonstrated that, as I said before, the average time for biopsy is just 8.5 minutes. And so let's face the facts. Not many people want to be lying in the doctor's office in stirrups with a probe up their rectum for a long time. And so having a fast and efficient biopsy technique is much better for patient care. And then the transperineal biopsy has a longer learning curve. So in an evaluation of resident physicians learning to perform prostate biopsies, there was a study that examined standards of quality such as average length of prostatic core specimens and absence of prostate tissue. So the real key determinants of whether we can determine if there's prostate cancer in that prostate gland, and found that only 12 procedures were necessary to perform those high quality truss prostate biopsies without compromising prostate cancer detection. That means that using the truss platform, nearly every urologist can obtain high quality biopsies quickly and efficiently. And then transperineal is just not good for many patients. So it's not good for patients who can't get into that lithotomy, which is the position with the feet ankles way up in the air, patients who are prone to increased pain, patients who have anxiety, patients who don't have extra time to spend in a procedure. It's likely more expensive. It's not good for patients who are considering focal therapy and patients who do not want a procedure that may require sedation with extra anesthesia. And so just in summary, transperineal is, yes, it's likely trendier and cooler, but it is more painful, it's more expensive, it has equivalent cancer detection rates, it's less efficient, it's not generalizable across practices. In comparison, transrectal has improved patient experience, it's less expensive, it has comparable infection rates, equivalent cancer detection, it's more efficient, and just more sensible all around. So for me, I like to compare it to a Porsche versus a Honda. Yes, a Porsche is, the transperineal is equivalent to a Porsche Carrera 911, and the transrectal is comparable to a Honda Civic. Yes, I would, a lot of the time really like a Porsche Carrera more often than a Honda Civic. until it gets time to fixing it, right? And overall, the Honda Civic just makes more sense. So the Choose biopsy is the gold standard. It's endorsed by the American Urologic Association. It's applicable to all urologists and patients. Thank you.
Okay. Well, Dr. Kaye, thanks for making the case. We'll see if you win. Now it's Dr. George's turn. So go ahead, Arvin.
Great. Well, I tremendously respect Dr. Kaye. And however, I think we're going to have to agree to disagree on this one, unless I can convince her to join my side. And before I get started, I'd really like to really thank Howard Walensky, Joe Gallo, Rick Davis for giving both myself and Dr. Kaye the opportunity to share some information about prostate biopsy in general, but force us to think about the other side. And also, of course, to Alexa from ANCAN, who's helped coordinate all this. So I'm going to get started. I changed my talk a little bit, at least the title, where it's like, why are we doing it any other way? And I'm hoping that when we finish here, that you'll agree with me that there really is no other option than transperineal prostate biopsy. These are my disclosures. None of them are really relevant to transperineal biopsy, unfortunately. Now, what are the objectives of this specific talk? So what I want to do is really highlight the status quo. Dr. Kaye did a good job kind of giving you the basics of what a prostate biopsy is, but I know there's only 10% of the participants so far that have never had a prostate biopsy before. So most of you may already be familiar with that. I'm going to talk a little bit about the rationale for transperineal access. I know that Dr. Kaye also mentioned or tried to identify some of the arguments up front that I may make, and also some of the outcomes of transperineal biopsy. And what you'll see is that both Dr. Kaye and I will use a lot of the same evidence or studies that have been done. But I'm a more glass half full type of person when I'm reading these studies. And I hope that you'll see these studies in the same way that I do. And then finally, I'll kind of go through the technique and what you would potentially experience as a person who's undergoing a transperineal biopsy. So there are about 1.97 or almost 2 million prostate biopsies performed per year in the US. And if you include both Europe and the US, that is almost 4 million biopsies per year. And the number of biopsies that are happening are not decreasing. There have been various recommendations made regarding PSA screening for prostate biopsy. But despite that, we continue to see a rise in prostate biopsies. So this debate that we're having today remains relevant and more relevant than ever before. The vast majority of biopsies are performed transrectal. And I think that our audience is a bit of a testament to that. The vast majority of men, 69% of men, I think, on our survey actually had a transrectal biopsy. And this is already with transperineal biopsy being available to a segment of men already. Now, biopsies in general result in about 5 to 7% of infectious complications. Now, that's not just sepsis. Sepsis is a severe form of infection that affects the whole body and different organ systems, that can affect your lungs, that can affect your heart and your blood pressure, but also encompasses fevers after biopsy, incorporates epididymal orchitis or infection of the epididymis or testicle, prostatitis, or urinary tract infection. So sepsis, or that most serious infection, is not the only infection that can be caused by a biopsy. Now, about 0.09% of men who undergo a prostate biopsy will die from that prostate biopsy. And now, this is a morbid statistic to put up there. And even though this number seems exceedingly low, if we take into consideration 2 million people undergoing a prostate biopsy per year, that is almost 1,800 men who are dying from a prostate biopsy annually. And the vast majority of these are most likely due to an infection or sepsis. Now, even though this rate is low, it should be an absolute never event, especially given the fact that we have the tools to be able to virtually eliminate the risk of infections and also infectious hospitalizations or sepsis. Now, we know that a lot of these infections that put men in hospital after the biopsy is really due to what we call fluoroquinolone-resistant bacteria. And fluoroquinolones are just a category of antibiotics that urologists tend to lean on because it does have a favorable profile in regards to its ability to penetrate the tissue and work well in dense tissues, and also that it concentrates highly in the urine. But as providers, we are really victims of using this antibiotic ubiquitously, where we use antibiotics such as ciprofloxacin or levofloxacin, and what has resulted is that we keep driving more and more antimicrobial resistance. And you may have heard of the term superbug. That's essentially what we've been generating. We throw more antibiotics at the problem, and we just end up in the same scenario that we started with. Now, in those men who do actually get admitted to the hospital after a biopsy due to having fevers or low blood pressure or just feeling lousy, the vast majority of those are due to having resistant bacteria. And so if we're giving somebody ciprofloxacin and it's resistant, we're basically not giving them anything. And that is a continued problem in prostate biopsy, and that there is a significant cost that's associated with it. Maybe there is, of course, a personal cost for a person who's going through a biopsy. That's terrible. They can be extremely sick, and they can virtually, and I've seen this very commonly, be in intensive care and require a significant recovery period. And there is a significant cost, both financial toxicity to a person or a patient, and also to the health system and providers. Now, Dr. Kaye mentioned some of these, and these are what we currently use to be able to help reduce our infection rates. But we now have one additional tool that can be used, or potentially even combined with some of the other tools that we see here, such as needle disinfection and antibiograms, if antibiotics are going to be used, to drive those rates even. She mentioned that they can be low, but we can make them virtually zero. So we have rising rates of infection. We have more and more bacteria that are becoming resistant to the antibiotics that we routinely use. However, what we can do is we can completely avoid the rectum altogether. As you can imagine, with a transrectal biopsy, it's exactly how it sounds. Every time the needle passes into the prostate, it goes through the rectum. So it goes through a contaminated space. So it goes through an area where there is feces and stool, and then goes into the prostate. And that is done a minimum of 12 times, potentially 16 to 20 times if we're doing a targeted or fusion biopsy. So a transperineal biopsy allows us to completely avoid the rectal flora and essentially get out of the sewer. And it offers us the opportunity to improve our antibiotic stewardship, even the ability to potentially eliminate antibiotics altogether. And there is now the ability to perform it in the office. I know that Dr. Kaye really stressed the sedation and the non-office aspect of it, but while I don't see that as a tremendous benefit from a patient perspective, maybe there could be arguments from a provider perspective. There is the ability now to routinely perform it under local anesthesia, and that is really how I do virtually all my biopsies are done under local anesthetic, both really the transperineal biopsies especially. Now, what I've highlighted for you on the right of your screen is the recommendations that our association that gives us guidance on what to do in these situations. Historically, and this is an older recommendation, that they give a fluoroquinolone or a cephalosporin. These are just different classes of antibiotics of fluoroquinolone, such as ciprofloxacin and levofloxacin, which I mentioned before. But I also showed you that the prophylaxis indicated for prostate brachytherapy or cryotherapy has a very similar approach to transperineal biopsy. The way to access the prostate is through the skin that sits beneath the scrotum. And there is really not good evidence that there is any benefit to giving antibiotics in those in these kind of procedures that are essentially through the skin rather than through the intestinal rectum. And when we look at the updated guidelines, this was updated by the American Urological Association in 2019. I'm going to highlight what the difference is. What they've actually, if you look at the fourth box, it says fluoroquinolone or cephalosporin, and then they said you need to use either one of those, plus you need to use another antibiotic, chloroaminoglycoside. So really, the recommendations of our field has been, why don't we just kick the can down the road? Why don't we solve this problem by adding additional antibiotics into the equation? I don't know what we expect other than that we're just going to drive more resistance down the road. So how do we get to the perineum? This is more of the technical aspects, but as patients who may consider having a transperineal biopsy in the future, this is really what it looks like. Either it can be through direct skin puncture, where we just take the biopsy needle and put it directly through the skin. You can use like a little IV catheter or intravenous catheter, which goes into the skin and stays there. And then the biopsy gun passes through that every single time, and you can direct the needle to the specific area of the prostate that you'd like. But what has really facilitated the adoption and really changed the way that we do biopsy are these transperineal access systems. But what they do is it just makes it easier for a urologist to be able to see their biopsy needle with an ultrasound when they're doing a transperineal biopsy. And while 3-4 years ago, there were only 1 or 2 options on the market, now they're continuously being updated. And as the market is becoming more competitive, it is becoming also more cost effective from the provider side. These are not things that patients will often see, but I think it's important to understand the complete aspect of this. We do it in the same way, a 12-core biopsy, similar to what's done with a transrectal biopsy. So you're getting no more and no less than the standard of care. And I just wanted to highlight a little video here, which shows how the biopsy is done. And I don't really want you to focus so much on the technical aspects of the procedure, but rather this is a live patient. This is the patient who is under local anesthetic alone. This is in our office. And this is actually, just so you know, this is with the permission of the patient, of course, but this is me while I am actually teaching another provider how to do it. And you can see that this person is rock still. They're extremely comfortable during the procedure. They're not jumping about. They're not flinching at all. The local anesthetic that we use is extremely, extremely effective. And so we give an initial block, some local anesthetic to the skin first, which is what you just saw, in addition to local anesthetic closer to the prostate. And that bright area that you see there is the needle going in and allowing us to give local anesthesia directly to the prostate. So one of the questions that I see sometimes some physicians marketing, but this is a common question that I get from patients is, how do we make these biopsies less painful? And I'm talking about specifically transperineal biopsy, because I do think that it is more uncomfortable than a transrectal biopsy, I'll be honest with you. But there are a number of things that we can do to help mitigate that or virtually eliminate it. So the first is a local anesthetic. Of course, that's administered, as you saw before. Oftentimes, these local anesthetics can be very acidic, and that can be the reason that there's the stinging sensation. So what you can do is you can change the pH of these local anesthetics using sodium bicarbonate, which basically makes it less acidic. Making sure that you put the anesthetic in the right place. That may sound like something that's obvious, but with this procedure being relatively new, there are many who are still on their learning curve and still tweaking the way in which they're able to perform to deliver the local anesthetic effectively. Using the right amount. When we first started, we were using high volumes of local anesthetic, and it was causing problems for patients. They would have fainting episodes sometime if they start to absorb some of that local anesthetic. But now that is virtually zero. I don't actually even remember the last person who's had a transperineal biopsy who has had any issues like that. Ethyl chloride is a cooling spray. That's oftentimes used for if you're going to get blood drawn, if you're going to have an IV placed, you spray it on the skin. It allows it to become really cold and numb for about 3 to 4 seconds. That gives you just enough time to be able to inject the local skin anesthetic, which is what you saw in the beginning of the video, and really reduces the amount of discomfort. Tylenol before a procedure is what we usually do, or the anesthesiologists routinely do before even surgical procedures that are done in the operating room. It essentially gives you a primer from a pain control perspective. And there are some non-local anesthetic techniques that I think work really, really well. I think being able to talk to the person who you're doing the biopsy on, walking them through it, making sure that they understand each step so nothing is a surprise. Playing music during a procedure can transform your experience. I recently had a wisdom tooth extracted. I put my headphones in, and it totally changed my experience during the procedure. I know that it is presented as a disadvantage, but I think from a patient perspective, it is not necessarily a disadvantage. We have a number of different ways in which we can do light sedation or conscious sedation where you're not completely asleep, you're still responsive, or you can have complete sedation as well. MKO melts use a midazolam, ketamine, and ondansetron. These are medications that help with nausea and help with analgesia as well. Those can be given. That's an oral or sublingual, something that you put underneath your tongue and melts. IV sedation, which is medications that are given through an intravenous line. Valium is a benzodiazepine, or a medication that both is an anxiolytic, so reduces the anxiety that can be associated with a biopsy, and also generally will reduce some pain control, or reduce some pain that's associated with the biopsy. And there are some newer options like patient-controlled nitrous oxide, where you actually have a small mouthpiece, you breathe in that gas, and it actually makes you feel, I wouldn't say lightheaded, but less concerned about what's going on around you. It certainly helps with the pain aspect of things, and also helps with nerves that exist with both either a transrectal or a transperineal biopsy, to be honest with you. So I'm not going to, so what I'm going to show you right here is, I know that Dr. Kaye wanted to show where the infections are really, really low, and she was right that I was going to highlight this. This is just, you don't need to pay attention to the numbers. What you need to pay attention to is that the resultant admissions for infections after a prostate biopsy in multiple studies with doing transperineal biopsies was 0.056%. That is virtually, you eliminate the risk of an infectious hospitalization. Now, we had mentioned a little bit about the use of antibiotics, and this can get a little bit more in the weeds regarding the study, but because this was such an important study, I thought it was really important to highlight it to the audience here. And this is hot off the presses, published in June of 2022. This was a randomized trial. So a randomized trial is the best type of study that we can do in our scientific field. It was transperineal with a medication called cefuroxime, which is an antibiotic, or transperineal without antibiotics. These were all actually fusion biopsies, but they did exclude some men who had a very high risk of infection. So maybe those men who are immunocompromised, who have immune disorders. They didn't want to put them through the potential risk of not receiving antibiotics. And really, the goal was, is there a difference between being admitted to the hospital within 60 days if you received antibiotics or not, if you're doing the transperineal approach? All you need to do is focus on the last 4 boxes. These are both arms of the trial. Basically, both had one urinary tract infection, and the difference between the two was 0. Now, in terms of other complications that can happen during a transrectal or transperineal biopsy, there was no difference in hematuria, no difference in urinary retention or the ability to urinate after the biopsy, and there was no hematochezia, which is the medical term for blood in the stool. So really very low side effects with a transperineal biopsy. And multiple randomized trials have shown there is no difference in the cancer detection rate or complications, okay? So no difference historically between the cancer detection rate, which has been some sort of a concern. When we look at other studies show that there is a higher cancer detection rate with transperineal biopsy. I was surprised that Dr. Kaye was able to find the single study which showed that it was worse with transperineal biopsy. Now, while the AUA, or the American Urologic Association, don't have any specific comments on transperineal biopsy, the European Association of Urology is a little bit more forthright and have embraced this much earlier than the Americans. And when their guidelines state that when the same number of cores are taken, both the truss and transperineal approaches have very similar cancer detection rates. So that is not an issue. How about the patient experience? Now, Dr. Kaye was right. There was a study which did show that the pain that is experienced during a transrectal biopsy is lower than transperineal. However, there are other studies which show the exact opposite, not the opposite, but show that they're equivalent. And interestingly, this Italian study only gave 3 milliliters of local anesthetic to the prostate. In general, we usually give anywhere from 10 to 20 milliliters. And while they only gave 3 cc's or 3 milliliters, there was no difference in pain scores between a transrectal or a transperineal biopsy. This is a question I get a lot. All you need to know from here is that there was no difference between transrectal or transperineal biopsy with urinary symptoms or sexual function from before or after the biopsy, either at 3 or 6 months. Very important to know. It's a common question that I get. Now, given the fact that there's some inconsistent numbers regarding how much pain does a patient actually experience, we tried to look at this ourselves within the state of Michigan. And what we found was that transperineal biopsy was more uncomfortable, but marginally so. If we look at the difference here, it's actually less than 1 point on what we call the visual analog pain scale. You may have seen it before. It shows you different faces from happy to sad and gives a number that's associated with it. Helps people identify where their pain actually is in that moment. We also asked men immediately post-biopsy, who both had a transrectal or transperineal biopsy, were the different parts of the procedure particularly uncomfortable or painful? And once the local anesthetic is given, there is really no difference in sampling the prostate from a pain perspective. Now, the local anesthetic is a little bit more comfortable, but that's only for about 15 to 30 seconds total. Now, how do we really address safety issues? We can take a look at some other industries that have a really, really strong safety record. I would say the airline industry is, I think, a good example of which takes safety issues very, very seriously. Many of you may remember the Boeing 737 MAX, and there were 2 flights that actually unfortunately crashed, which actually caused the death of more than 300 people who were traveling. Now, what was the response? The response was that they ground all of these planes and they figure it out. Safety was the number 1 issue and concern here. And they identified a couple of issues. One was pilot training. And the second was there was a faulty sensor in some of these planes and there was some equipment malfunctions. And before allowing these planes back online, there was a significant amount of investigation and study done before they would allow these planes to fly again. And I'm not saying that there was no problems even after that. But the point is I think that this is very similar to what we do in prostate biopsy. We have a piece of equipment that doesn't work correctly. The transrectal probe and doing a transrectal procedure is not right. What can we do? We can train our pilots. We can train our urologists to do a better biopsy rather than making excuses and saying that it costs too much or it's too difficult to learn. At the end of the day, it's a prostate biopsy, and we do this routinely. So again, within the airline industry, this is a view of the cockpit, a really complicated space. And it's very similar to when we're doing a prostate biopsy. We have the ultrasound machine. Sometimes we have a fusion biopsy machine. We've got buttons here and there. We have a screen, 2 screens in front of us that we're looking at. We've got different colors, things beeping, and it's hard to focus on what's really important. Now, in the airline industry or in a cockpit, it's not that common to have a button that if you flip that button or you press that button, it's going to crash the plane. And if it did, they wouldn't say, hey, let's put a sticky note next to this and say, do not press, crashes the plane. In the airline industry, what they do is they engineer the problem completely out of the equation. Don't allow that button to be in the cockpit if it can crash the plane. And that's exactly what we try to do with transperineal biopsy. We engineer the problem out of the equation. If the rectum is the problem, if the contamination from stool and feces, and that's what's driving infection, which it clearly is, why don't we avoid that completely and engineer that out of the entire equation? So as we continue to work to make this better, we are working on eliminating antibiotics. And while Dr. Kaye is right, there are still a lot of providers who continue to use antibiotics during biopsy. That is changing. Within the state of Michigan, 63% of transperineal biopsies are performed without antibiotics. And as I mentioned before, with a recent study that was published, that is a practice-changing piece of scientific data. It shows us that there is no difference if you use antibiotics or not. So we can safely omit antibiotics, especially in those men who are not at high risk of infection. We're working on training additional physicians to be able to reduce their learning curve and also reduce the cost that's associated with biopsy. I want to highlight actually a really proud moment of mine at the top. The picture that you see there, that was the course that we ran on transperineal biopsy in 2019. And I was able to convince my dad, who you see standing next to me, who's also a urologist, to actually stop performing transrectal biopsy. And we were actually able to participate and teach other urologists together. Now, within the state of Michigan, we do have a number of, if there are any providers on the call, on the webinar, we do have a number of resources to get you going. And what I've highlighted here is something that we've created specifically for patients. An educational video which talks to you about what to expect during a biopsy, what to expect after the biopsy, and everything in between. It's a short video that takes about five minutes, and I routinely use this for all my patients who are considering a prostate biopsy. I'd like to thank you and really welcome questions from the audience, and looking forward to hearing Dr. Kaye's counterargument.
Well, Dr. George, thanks for the presentation. Before we get into the questions, we're going to run the poll. Joe, do you want to do that? And then I'll lead into the questions.
We'll let it just go a little bit longer to make sure we get everybody's input. Okay, here we go.
Okay. So it looks like we changed some minds here. Let's see. It comes out 23% now favor transrectal, 43% prefer transperineal, and about a third, 34%, had no preference. Now, maybe we can take the next 10 minutes and the two doctors can rebut each other.
Not physically.
I'll start for Dr. George. You know, he did have some convincing arguments. I'll give him that. But my question is how much pain or discomfort is acceptable during prostate biopsy, and what's the trade-off you're willing to make as a physician for such a minor improvement for infectious hospitalizations?
That's a good question, and I think that value proposition is going to be different for everyone. And I think that there is a doctor perspective, right, where we take any marginal benefit, even if it's more uncomfortable for the patient. That's kind of the physician's view of things, but there's a patient's view of things. And I've had people who are close to me who've had to undergo it, and to finally actually be able to talk to them and them tell me what their real experience is makes a big difference. And so, how to answer your question is, I actually don't think that there's anything wrong with doing a biopsy under sedation, or using nitrous oxide, or using an anxiolytic that can help during the procedure, that can reduce it. Now, as physicians, as doctors, we tend to say, oh no, that's terrible, they have to have the procedure done under anesthetic. But you can do it in the office under a lot of these medications. And if there is somebody who requires sedation, and it's not uncommon that I do these procedures as well under sedation, I think that's 100% appropriate. There's absolutely nothing wrong with that. I'll ask Dr. Kaye a question. Now, I hear this argument a lot that, hey, this is so expensive to do this procedure. This is gonna cost so much. It's like why is it that a transperineal is too expensive for a practice or a physician when compared to the transrectal biopsy procedure?
Yeah, so we spoke a little bit about why it's more expensive, why the transperineal is more expensive, and it really gets down to the capital costs, disposables, time, the requirement for specialized staff, the dedicated procedure suites. First of all, the capital costs. We'll go just a little bit more into that. The probe alone, right? So the ultrasound probe. Not every vendor makes a probe that's compatible for these transperineal biopsies, and these can cost between $18,000 to $20,000. That's one single probe. And the lithotomy, so the stirrups to get patients into the correct position, can be $5,000 to $10,000. As we discussed, there's more use of local anesthetic, as well as sedation. All of this sedation and can require these dedicated procedure suites and specialized staff, and just the increased time that it takes to do these things. So the main thing is a lot of these costs, they have to be claimed by someone, right? And so that makes these procedures more expensive for the patient, and also if something's under sedation, that's more time off of work. If it's more time that the patient could be doing something else rather than undergoing one of these uncomfortable procedures.
Well, you mentioned the lithotomy position. What's like the routine? What is the routine course of a normal transrectal prostate biopsy?
In terms of like what happens afterward, well, or during. So the patient, is usually given kind of pre-procedural teaching. We get a rectal swab. When they come in for the day of the biopsy, we get them positioned in a very comfortable position, almost like they're sleeping on their side, right? Many patients have had one in this audience today, so kind of know the position. And place the ultrasound probe, use anesthetic to make sure it's comfortable. You spoke about some of the music and other things that can make the procedure even more comfortable. And then afterward, patients tend to do well, right? They, we talk about, the risk of bleeding and just making sure to stay hydrated. Bleeding in the urine is, as well as occasionally per the rectum. And those are the main things with a prostate biopsy. Yes, we do discuss, if you have fevers or chills in the first couple of weeks afterward, you need to contact us immediately or go to the emergency department. But overall, patients do fairly well, and the procedures are fairly well tolerated in clinic, and that includes fusion biopsies as well. So I have a question for you, Dr. George. I've heard that, and this goes with the training as well, but I've heard from pathologists who read these cores that the quality of the cores for transperineal biopsies are actually worse than during transrectal biopsies. And so I wanted to know your thoughts on that.
Yeah, well, I'll answer that in two ways. One is I showed multiple studies which show that the cancer detection rate is not different. So I'm not, this concept of the quality of the cause not being the same, if it doesn't affect the cancer detection rate, I'm not sure really why that's a concern. That's one thing.
Just one thing quick with that. Is that because these are all, clinicians who have done thousands of transperineal biopsies? Because in reality, right now, that's not really the case.
Yeah, well, there are some technical aspects of the procedure as well. So with a transrectal biopsy, you're never ever gonna miss the prostate, and you're never ever not gonna have a full length core. And that's just because of the orientation of when you're taking the biopsies. And with a transperineal biopsy, it's a little bit different. So your cores can technically be shorter. And so I think that can impact the quality of the cores. But again, if it doesn't make a difference in the cancer detection rate, I think it can only improve it once people kind of understand the way to get a good core sampling every single time. And that was an issue for myself when I first started. There wasn't really a tremendous amount of guidance, and so I think over time we were able to understand that there were differences and change our biopsy technique to be able to accommodate for that. Well, there's one thing that I want to ask to you, and while I think it's really, really important, I know that from a patient perspective or from most other physicians, it may not really be a big deal, and that is antibiotic stewardship. It's a more abstract concept, right? Saying, hey, let's not use as many antibiotics, and it's less tangible when you see that there's less bacteria that are becoming resistant. It's not something that everybody's jumping up and down and saying, yes, this is why I want to do transperineal biopsies, though I do think that it has probably the most significant impact overall in why we do these transperineal biopsies. So how important do you think it is? And is it something that motivates you, or is it something that motivates the other providers in your practice, the patients that you see? I feel that most patients maybe get some reassurance from taking an antibiotic, even if it's not technically required.
Yeah, no, that's a good question. Antibiotic stewardship is extremely important, right? We know that the rates of these resistant organisms are going way up, and that makes prostate biopsies become more dangerous in the future, or that they will become more dangerous in the future. I do think it's important. I think with our there are certain things that we're doing, as you mentioned, into biograms, and the huge thing is the rectal swabs, where we're really able to, decrease the amount of antibiotics used and really tailor the antibiotics to the organisms that are in the area, as well as the organisms of that individual patient, are critical to help with antibiotic stewardship.
Would you ever do a transrectal biopsy? Given now, I may have baited Dr. Kaye a little bit here, but given how important you think that antibiotic stewardship is, would you ever consider doing a transrectal biopsy without antibiotics?
No, I wouldn't. But the fact of the matter is, a lot of people who are doing transperineal are not doing it without antibiotics either. And that could be that they don't feel comfortable with it. It could be a patient education thing as well. But the fact of the matter is only 10% of clinicians who are doing the transperineal in one study were doing it without antibiotics. So yes, it is a potential benefit, but we're not there yet.
Do you think that will change with our most recent study, the NORAP study?
I'm not sure, because I think, there are pros and cons to both transperineal and transrectal. And so, if everything does go over to the transperineal, hopefully it will. But there are things, that we've adjusted, that have been changed on the transrectal side, where we are getting better with antibiotic stewardship, and to make these, procedures more comfortable. We need to make sure that these procedures are comfortable, and that it's easy for patients to get them, and that they're safe. And I think the transrectal approach meets all of those criteria. So, Dr. George, if you were to have a prostate biopsy, what would you undergo? And exactly how would you undergo it?
Well, and exactly how would I undergo it? That's a good question. So I think that for me it would be, and I think this is a personal choice, because I think based on how you're asking it, that it would be important for me to have as little downtime as possible. And so I think doing it under local anesthetic would be my preferred option. But I'm also a chicken. And so I wouldn't mind something that could take the edge off, whether it be nitrous oxide, where I could just use it for 5 minutes and then still be able to drive myself home, for example, with zero effects. That's the way that I would do it. And well, let me ask you, this may be the final, this may be the ultimate the ultimate question here. What would you do for, let's say, a family member? I know that prostate biopsy may not be relevant for you, but if it was your own family member who needed to undergo a biopsy, what would you recommend to them?
I would do a transrectal under just local anesthetic. As I said, it's safe, it's efficient, patients are comfortable, and I know that the quality of the biopsy is going to be high.
You can still change your mind. There's still time, Dr. Kaye. All right. Well, are there any questions? Yeah, go ahead. Yeah, please.
Maybe this would be a good transition now. Since we're running a little bit longer, I hope that the two of you can be patient and we can extend beyond the time. Let's see here. I do need to share something with the whole group. It's a little over to here. I'll put it in. This group, along with the ASPE group and others, Canadian group, PCRI, and the Active Surveillor newsletter, going to be running a course that we call Active Surveillance 101. And I put some information in there. It's pass-fail. You define the fail yourself. And so anybody that's interested can sign up. Our first session is going to be with Dr. Span, and our next two sessions will be with Dr. Klotz. And then we have Dr. Epstein lined up, and who knows, maybe Dr. Kaye and Dr. George might join us later. We'll decide after the sudden death exchange, but any rate, so anybody that's interested, take note. And then we're going to have some questions. I want to open it up. I mean, Dr. Kaye indicated that regarding the AUA, that they had a certain position. But I need to point out that the AUA has started internal debate on what the future is going to be with transrectal versus transperineal. And they'll be coming out with guidelines next year. So we'll see who has the final word. But it's true that in Europe, they've already decided this for themselves. And I wonder how the two of you react to the fact that there, at the moment, is a contradiction. In Europe, I was talking to one of the leaders from the European Association of Urologists. He said in Europe, transrectal is considered malpractice in Europe. So how do you contrast that with the United States, and where do you think AUA is going to go? I mean, the practicalities are different. The points of view of the doctors are different. It involves money and it involves training. But where do the two of you think the AUA is going to go on this next year?
I think that, with regards to Europe and transrectal being malpractice, while I strongly favor transperineal biopsy, and I do think it's the better biopsy, I don't think that it's malpractice for a couple of reasons. I think that there are still, just like Dr. Kaye mentioned, there are some limitations to transperineal biopsy and you can still get an excellent biopsy. There are many practices, there are many providers who've done many biopsies, and they have an exceedingly low infection rate. That's a common question that I get. I'll have a provider or a physician who'll say, hey, look, I did, my last 800 biopsies, I didn't have a single infection. Why would I switch to transperineal? And, for them, it's, my answers are, one is that you can't predict when that event is going to happen because it's a very low event rate in general. And if you have a solution that can make it, 0 based on data. Why wouldn't you? But I totally understand that if the difference is 0.5%, then does that mean that one procedure is wrong and one is not? No, I think that it's part of an informed discussion with your physician and with the person who is going to undergo the biopsy, honestly. And then to your second question regarding where do I think the AUA will go, I don't think the AUA will necessarily put out a very strong statement either way, for a couple of reasons. One is I think that, as I mentioned before, transrectal biopsy is still a very good biopsy, and it's the standard of care, even though it has its issues. That's one. And the second thing is that the AUA, even the EAU, but the AUA particularly so, is very, very reliant on making sure that there are studies that support one indication, one type of procedure or one recommendation over the other. And I mentioned before that randomized trials are going to be the highest scientific study that we can produce, and there are a number that are currently underway. And so they may reserve their final judgment until the results of those studies come forth, but certainly they will acknowledge that it exists, acknowledge that its advantages, but I don't think they will strongly favor one versus the other. That's my thought. So
Dr. Kaye, what do you think?
Yeah. So I think similarly. I don't think the AUA, at least coming up shortly, is going to strongly endorse one or the other. We've both described advantages and disadvantages to both the transrectal and transperineal biopsy. I think you can get good, safe, efficient biopsies with either approach. We've discussed the advantages and disadvantages, and Dr. George, brings up an important point, is we really don't have, large randomized controlled trials and really enough data comparing head-to-head, making head-to-head comparisons, and really comparing apples to apples, right? If you look at a lot of the studies, it's maybe comparing apples to oranges or some similar variety of things, but we really do need kind of head-on comparisons. Now that things have kind of progressed with transperineal, and that we've made some changes with transrectal as well, we really need the trials kind of in this era with how people are doing them and have done them, in order for the AUA to make some strong recommendations.
Gotcha. Now, something I want to point out, just not necessarily for comment, but I believe, and I think Dr. George and maybe Dr. Kaye can back me up on this, I think nationally, US only, about 5% of the population eligible for transperineal versus transrectal, only 5% have opted for transperineal. But if you look at the numbers from this group, from the first slide, the first poll, it's really 16% of this audience, 7 plus 9%, 16, who've actually had transperineal. We're going to, before we finish, we'll ask the poll one more time. But Jim, are you ready with some questions?
Yeah, I think so, Howard. We've got a lot of questions, and I'm trying to group them a little bit so that we can try to answer most of them. I think one of the first ones that comes up is it's really a question about whether a transperineal or transrectal biopsy can reach different parts of the prostate. And the question specifically is, does a transrectal biopsy sample the backside of the prostate as well? The side the urole cannot feel with DRE. And the same question, what about transperineal? And I think, that's something we haven't talked about really too much tonight, about whether the transperineal can actually reach different areas. An argument I've heard, at least.
I can start with that, and then I'll let Dr. George follow. There was some question if transperineal. Sometimes people say, well, transperineal gets anterior, gets anterior tumors more commonly, and the data is mixed about that. And really the question is sometimes with transperineal, it's much more difficult to reach certain parts of the prostate. If the patient has a very large gland, sometimes transperineal can be more difficult, or a very narrow pelvis, then it can be more difficult. Otherwise, Dr. George, I'll let you continue on.
Yeah, so I think that with either biopsy, you can reach anywhere in the prostate. Now, with one technique, it may be slightly more challenging than another. So transperineal may be a little bit easier to reach the anterior prostate, but you can reach anywhere with either prostate biopsy. Now, the question though is that do you routinely sample the anterior gland? Usually not, because that's generally not where prostate cancers hang out. And now with the use of prostate MRI, it tells us where to go the vast majority of the time. So we don't have to randomly sample the prostate to be able to say, oh, well, this, we were able to sample this area better or this area better. We can reach anywhere with either technique, and MRI tells us where to go. So I think that those historical concerns should not be concerns for experienced providers.
But that being said, we don't get MRIs on every single patient, right? We are getting MRIs more and more, but that's only, Dr. George and I come from high volume academic centers where we have, we have a ton of experience reading MRIs, and we have really high quality MRI machines. And so, while, I know in my practice, I often will get an MRI. At least before an initial biopsy for an elevated PSA. There are a lot of practices where it's just not as helpful because of how the MRI is done and how it's read. And so for that, there can be a little bit of differences in terms of, how we sample and what we need to sample.
Dr. Kaye, you mentioned the issue of urinary retention. And I'm wondering if you were citing more historic data, or are you referring to some of the newer techniques as well?
The newer techniques, regarding.
Well,
there are studies that, and by newer I mean, in the past 5 years or so that cite higher rates of urinary retention. And in fact, when we're kind of developing some of these indicators for national databases, this is one of the things we're talking about is really to be able to more accurately track, transperineal versus transrectal, and if there are higher rates of urinary retention, because it is something that we have seen in inflection points in other studies. And while, as we said, we don't really have good head-to-head randomized controlled trial data, now we're trying to gather as a urologic community on a broader level as part of quality improvement initiatives about some of these complications, including urinary retention.
Dr. George, there are a couple of questions from patients looking for, asking how can they find a doctor who offers transperineal? If it's not available, is this a moot question?
Yeah, no, that's a great question. There are many providers now who are offering transperineal biopsy that, when we first started 4 years ago or so, I think I could name every single physician in the state who does transperineal biopsy. Now I'm hearing more and more providers learning how to do it independently, going to training sessions, getting trained by their peers. And I think it's becoming more and more widely available. But in terms of being able to identify a doctor, it's ultimately, these are some of the things that are going to be driven by, the patient's voice. And so if you go to your own urologist and you say, hey, I've looked at and learned about both types of biopsies. My preference is a transperineal biopsy. Can you please, do you do them? And if not, can you refer me to a doctor who does? I think that does two things. One, it'll get you where you need to be. Second is it'll put an impetus on that own urologist to say, okay, this is something that is a safer procedure, and it's something that patients would like for that reason.
You know, one of the folks asked Dr. George, why did you make the switch?
Why did I make the switch? Yeah, so yeah, that's a great question. So it was, I remember one of the things that we routinely do in an academic department or even a non-academic department is that whenever there is a complication or an issue that arises for any patient that we see of all the providers, it's presented every month and we discuss it. And every single month, without fail, there used to be a discussion regarding sepsis and biopsy. And we have spent years on the things that I have shown you previously, and both Dr. Kaye and I showed you that reduce the infection rates for transrectal prostate biopsy, using needle disinfection, augmented prophylaxis, which means giving more antibiotics, giving iodine enemas, doing all sorts of things. And we've spent years and years and years. And what we've done is either it's flatlined, increased, or in very efficient locations, it has shown decreases. But that's after years and years and tens of thousands, millions of patients to be able to get marginal decreases with these technique modifications. With one thing only, switching from a transrectal to a transperineal technique, we're able to virtually eliminate all of the most serious infections that can happen. And that's the reason why I saw that the potential and the difference in a single technical modification versus years and years of changes to our procedures, our techniques, and studying these, that we were able to make very, very minor incremental changes.
Yes, but that being said, we've done years and years in research in that other area, and we have that data, and we have those things to decrease, and with your own music data. I mean, your music data alone shows that the risks of infections and hospitalizations with our other techniques are incredibly low. And there are still some real benefits, including patient satisfaction and experience. There are some real benefits with transrectal.
So Jim?
Yeah, this one was concerning trust. What is the perspective on traditional fusion biopsy, that is static MRI image versus in-bore, that is real-time MRI imaging? And I think a question that follows from that is, are both techniques, do they accommodate this?
Yeah, I can take that question. So in-bore versus, there's three different types of ways of doing a fusion biopsy. So one is in the MRI, where they scan you, they see an area of suspicion, they can put the needle under MRI guidance. Okay, as you can imagine, that's clunky. It requires you to be scanned multiple times. It's difficult. There's software-based fusion, where you take your static MRI, like you mentioned, you take a software program where you can basically overlay it on top of your prostate ultrasound, and then you can sample it. And then there's something called cognitive fusion or visual registration, where you look at the MRI and you say, okay, it's a little bit to the right, a little bit up, and then you sample that based on what you see in ultrasound. This has been studied extensively in, like I mentioned before, randomized trials, which is the highest level of evidence, and it has shown really no difference between any of those techniques. So as long as you're using an MRI for guidance, you're likely going to get a good biopsy from a cancer detection standpoint. While there are some minor caveats, meaning very large prostates, very small suspicious areas, they can maybe favor one technique or another. For the large part, it makes no difference. So that's the answer to the first question. So the answer to the second question from Jim was that, can you do transperineal fusion biopsies and can you do transrectal? This is, when we've looked at our own data, this is hands down. There is a 1.6 times chance, or a 60% increase in infectious hospitalizations if you're doing a transrectal fusion versus a transperineal fusion. Well, now, there may be a few reasons for this. One, you're taking additional samples. So if you're taking additional samples going through the rectum, when you're going through the perineum, it's probably not making a big difference. But when you're going through the rectum, it probably does make a difference. The second thing is that with fusion biopsies, it's a longer procedure. There's a little bit more manipulation of the prostate, which can maybe increase the risk of seeding the prostate or seeding the bloodstream with bacteria. So both techniques can be done under fusion. If you're going to undergo a fusion, or at least if I was going to undergo a fusion, I would strongly favor transperineal because it's, at least based on our own data, it's unequivocal the risk of infection is lower.
Okay, we had another question. Dr. Kaye said the transperineal biopsy is not appropriate for patients considering focal therapy. Why is that?
Yeah, so usually when you're considering focal therapy, you want it's usually better to undergo things in the OR. You often will potentially take, we need to do a template. We need to make sure that everything's mapped out appropriately, the prostate is appropriately mapped out. And so it's really important that patients are completely still and that we can take the number of biopsies that we need. And so that's why that it's best done in the operating room. And I'll let Dr. George answer more as well.
I will say no way, Jose. That's does not required at all. I very rarely do transperineal saturation biopsies, and that's because of MRI for focal therapy. Now, I don't disagree with Dr. Kaye in that not everybody gets an MRI, and just doing a standard 12-core biopsy, if you're going to be considered eligible for focal therapy, you should have a saturation transperineal biopsy under anesthesia if you don't have the option of having an MRI. And there are some men who don't have the option of having an MRI. That could be if they have a metal implant or metal fragment. We see that very common in the vets that we take care of. So they would not be able to undergo an MRI. Or if they have hip replacements, which can obscure the prostate during an MRI, yes, they would have to really undergo a transperineal saturation biopsy. But for the vast majority of patients, I think that it can be done transperineally or transrectally and as a fusion biopsy, not in the OR under local anesthetic.
And once again, that's the difference of opinion, right? So we at Duke do everything for focal therapy. We do this in the OR under sedation because we think that we can get a much better mapping of the prostate and have a better idea of exactly where we need to treat and how we need to treat. And the data for focal therapy is, in terms of our other therapies, is much younger. And so this probably still has we need to follow this data and probably need randomized controlled trials in this area in order to kind of better figure out the best way to do this.
And, transperineal saturation biopsies for consideration of focal therapy, I'd argue that that's the Porsche. The Civic, which Dr. Kaye enjoys as well, would be a fusion biopsy done under local anesthetic, which, like she said, may be a difference of opinion, but I think it's appropriate.
I'd like to include a couple of questions that were submitted by the audience in advance. There's two of them. One of them comes from a man who says he's experienced ED side effects 12 weeks ongoing from a transrectal initial biopsy. Would a transperineal approach to future biopsies offer less of a risk of repeating or making worse ED side effects?
So that's actually a pretty common question, especially with the transperineal approach. Our data suggests that there is no real difference in terms of erectile function and quality of life between transperineal and transrectal.
But can there be an impact on sexual function as a result of the biopsy?
With repeated biopsies, I think that it's going to be the same for the transrectal or transperineal approach. I did present one short series or two studies which showed no difference at 3 and 6 months for erectile function. Now, I think that it's kind of like your prostate's getting beaten up during a biopsy, and it does require a little period of time for recovery for the most part. It's kind of like, if you get punched in the gut, you don't get up right away. You need to take a minute to catch your breath, and then you can get back on with business. And I think with repeated biopsies that may be the case, because you can have scarring, maybe hemorrhage close to the nerves. There are a number of theories. If the question is, if you're doing one approach versus the other, a 12-core transperineal biopsy versus a 12-core transrectal biopsy, is there going to be a difference? I don't think there is. We will see that definitively based on those studies that are currently being done. But to date, there is no evidence. There's no studies that have shown it. And anecdotally, I have not noticed any difference in my own patients who've undergone either procedure.
And one more question.
Howard, hold on a second. Dr. Kaye was going to comment there.
Well, I was going to say the same thing. It's really going to be up to those randomized controlled trials coming up, because it does, there are different, nerves involved, and physiologically it could be potentially a little bit different. But we do know, if that was part of the question, we do know that with repeat biopsies, there have been reports of some, increased sexual dysfunction after, multiple repeat biopsies.
Okay, Howard, just before you jump ahead, I just wanted to mention for the audience, both doctors have agreed to stay around a few more minutes, a couple more questions, and then when we end up, we're going to do one more final poll for those that are still present.
Okay, I want to close out the mailbox of people who submitted. We're a group that focuses on active surveillance, but I'm assuming our audience includes people who are not necessarily on active surveillance. And I wonder the relevance of this debate for those men, first of all. And second of all, I got a note here from one man who asked, regardless of whether transperineal or transrectal, is it necessary or recommended or useful to have a prostate biopsy following radiation treatments if PSA is not elevated?
So I'll answer the first question in terms of, sorry, remind me of the first question again. I apologize.
Yeah, what is the relevance of this beyond active surveillance?
Of the transperineal versus transrectal, beyond active surveillance or for active surveillance?
Forget about active surveillance. I'm trying to raise a question for people who are not on active surveillance.
Well, I mean, it's all about the initial biopsy, right, and diagnosis of prostate cancer. And so Dr. George brought up the point initially about we do an incredible number of biopsies per year. And a lot of, while some patients are on active surveillance, a lot are just for elevated PSAs, and a lot turn out to be negative. And it's important that, as I mentioned before, it's important that we offer a procedure that is safe, effective, and accessible, and that patients aren't, totally petrified to undergo, right? Because you hear from a lot of men undergo prostate biopsies, and so we really need it to be, a safe procedure, that people don't defer care. Because it's prostate cancer, as we all know, is common. And so we need to continue to do the prostate biopsy in the best possible way.
I'd like to answer that as well, Howard. The question is it relevant? Is it relevant to me if I'm not on active surveillance? So, you may be a person who would only be essentially undergoing a single biopsy. Now, I'm the kind of person where if I'm going to buy something, I need to research it incessantly and make sure that I'm getting the top of the line. So whether that be, a Bluetooth speaker, I need to know every single feature and make sure that I get everything that I want out of it. If you're only going to have a single prostate biopsy, that doesn't mean that you don't get the best possible biopsy that you can. And the event rate is independent. Yes, somebody who undergoes repeat biopsies has a greater risk of potentially experiencing the bad issues of each biopsy for that matter. But even if you have it only once, I still think it's extremely relevant to you.
What about this?
Howard, excuse me for interrupting, I'm sorry, but I think in that question, didn't the questioner comment post-radiation?
Yes, that's what I was going to bring up. Specifically, yeah.
So for post-radiation, there are a number of different scenarios. So I think it's really hard to comment on it because the way the radiation works is it doesn't cause the PSA to go down like very rapidly unless you're getting hormone treatments with it. And how it works is it induces DNA damage into the prostate cells, and they die off slowly. So it can take up to 2 years for your PSA or for your prostate cancer to be completely treated with radiation. And there are some radiation oncologists who do advocate for a biopsy to verify that there's a complete treatment effect. But I would say that's not the practice at our own institution, and I would say it's not necessarily the standard practice amongst most radiation oncologists, but there could be a reason where your PSA may not have, may not be elevated per se, but it may not have decreased to the value that it should or be appropriately decreased through a treatment. So individual cases, very hard to comment on.
Yeah, Jim, why don't you field a few more and then we'll wrap.
Okay, this question combines a couple questions that we got from the audience. And first for Dr. Kaye, are there any circumstances where a patient who has other conditions, irritable bowel disease, Crohn's disease, or something like that, where you would recommend a transperineal approach as opposed to TRUS?
Yeah, I mean, that's a really good question. I think, I think anything that's affected the large bowel, if they've had kind of definitely if they've had repeat infections or required a lot of antibiotics in the past, and maybe more resistant, and especially if for some reason I can't get them in for a rectal swab, I would probably recommend a transperineal. And then if they have some kind of pathology that affects the large bowel, I also may be, leaning more towards transperineal in them. That doesn't mean that we can't safely do a transrectal biopsy in many patients with these certain pathologies. But if it's available, and if we kind of discuss the risks and benefits of both, I may potentially lead them more towards transperineal.
Jim, anything more?
I'm scrolling through the list, which is lengthy. There's one kind of broad question here about resistance to change by urologists, and are you seeing that there's resistance? And if the AUA were to perhaps change its guidelines to say that transperineal was the preferred approach, do you think that providers would refold, or what? It's really kind of a question about the politics of all of this and the AUA, and I'm just curious what your views are on it.
I think once again, as we've said before, there are benefits to both approaches, right? And so until we have these high-level randomized controlled trials, these head-to-head comparisons, I don't think it's so much a resistance to change, as well as there is no real reason potentially to change. And then it also gets back to, right, if we do find that in these randomized control trials that yes, on multiple levels, transperineal is the way to go, then, there has to be some help and some, policy, stimulation in order to help allow practices to be able to do a lot of this, right? A lot of it is really expensive. And it's hard to talk about money in medicine, but when it comes down to it, you know, we have to be able to keep on providing certain procedures. And if something is a lot more expensive, then sometimes it can't happen, right? And so it may require something from, you know, from a policy bent in order to provide some sort of, you know, capital investment or something to allow practices, you know, especially super high volume practices, you know, or sorry, especially practices that aren't very high volume, to be able to get some of this stuff up and running, because it really does require a huge investment. And, you know, so I think that that's really important from a policy perspective. But right now we don't have the head-to-head comparisons, and there's no clear, I mean, that's why we have these debates, because there are pros and cons about transperineal and transrectal, and there really is no clear evidence about which way is the right way to go.
So we'll give Dr. George the last word. Then we'll run a final poll, and then we'll thank our speakers.
Sure, thank you.
George.
Yeah, so, you know, there are 2 million prostate biopsies performed per year in the United States. 2 million biopsies. Challenging dogma is extremely difficult. Changing practice is very difficult. It is similar to changing course with a ship. You don't, with a huge ship, you don't just turn right and then you're going. It slowly changes, and that's how what we've seen in any of these disruptive technologies, these disruptive procedures that have happened in medicine, but specifically urology. It takes time to change, and it will change. I know that Dr. Kaye mentioned that we need to wait for randomized clinical trials, but we have good, strong observational data, meaning rather than saying, hey, we're going to do this and then we're going to follow you, we do it and then we see how they do afterwards. And we have tens of thousands of patients. And I presented with you some of that data that basically tells you that, yes, it's not a randomized controlled trial. But does that make that 0.056% risk of infectious hospitalization any less meaningful? Absolutely not. And so I do think the tide will change. Changes in guidelines will certainly facilitate that. But until then, I think that it will be the patient's voice that will be heard the loudest.
So, okay, I think each of you can give us a brief summary, and then we'll run our poll. So, Dr. Kaye, you started it. Why don't you start the ending?
Okay, I mean, you know, after all this debate, trust biopsy should still remain the standard of care. We know that infection rates of trust biopsy are extraordinarily low, less than 1% with our new techniques. We know that patients are, you know, require less time in a really extremely uncomfortable position. It's more convenient for patients because it's, you know, easily accessible. It can be done at, you know, most any doctor's office. And, you know, especially, you know, for patients who can't travel as much, that's a huge barrier to be able to getting biopsy. We know that trust biopsies are more comfortable. I mean, Dr. George, he said, yeah, we can make them a lot more comfortable, transperineal biopsies, but half the things that he listed were requiring sedation, which has, you know, its own risks. We know from multiple studies that there's an improved patient experience. We know that it's less expensive, and that's for the practice, but gets ultimately transitioned to the patient. We know that there are equivocal cancer detection rates. So yes, you're going to get good cancer detection from both mechanisms. And we know that transperineal can be difficult for some patients. So patients who can't get into lithotomy position, and patients who are increased to, you know, to have, you know, higher levels of pain. And then there, you know, there's some data to suggest that you maybe get a worse biopsy with transperineal. And yes, there's equivalent cancer detection rates, but those are from series where, you know, clinicians have done numerous, you know, biopsies, and it does take longer and a much longer learning curve to do these transperineal biopsies. So once again, trust should still remain the standard of care.
Okay, Dr. George, your turn.
Thank you. So thank you, Dr. Kaye, for engaging in this debate with me. And again, to the group, I didn't thank Jim before, but thank you, Jim, as well, for including us. When I think about transrectal versus transperineal biopsy, I really go back to the analogy that Dr. Kaye gave. It's like, why would I drive a Civic when I can drive a Porsche? You have the best biopsy that exists. Virtually eliminate. This is unheard of. There is very little that we can do in medicine that can achieve the results that we have achieved. Virtually eliminates the risk of infections altogether. There's a cost that the urologist may have to absorb. Their kids will still get through college. I assure you that. But you will get a safer biopsy. You will have minimal discomfort. Virtually all of the procedures that I do are done under local anesthetic. And the data that I showed you that it's not that transrectal biopsy has no discomfort at all. It's just marginally better than a transperineal biopsy for that very short period of time in which you get the local anesthetic for that 30 seconds. I hate using this example, but it's like when you go to the dentist. You get your shot of Novocaine. That stinks when you get it, but after that, you don't feel a thing. You just feel things moving around. And that's very much like what it is in transperineal biopsy. So I hope as you take this next poll, that you don't get frightened by Dr. Kaye's scare tactics, but rather you look at the thousands and thousands and thousands of cases of observational data that exist that shows that we can avoid 1,800 deaths per year from a prostate biopsy. So I urge you to vote for transperineal biopsy.
Okay, Joe, why not? Or Alexa, whoever's running the poll, why don't you run the poll? And thanks to our two.
I think it's between Alexa and Rick.
Oh, okay. Well, I'm going to throw up.
So Alexa's going to put up the poll right now because I have no idea how to do that. And the final question says, after tonight's debate, which type of biopsy will be your next biopsy? So all the audience out there, please vote. I can assure you as to the legitimacy of our voting machines here. They've been properly examined and authorized, and this will be the final vote. Just want to say that the votes we hold on this forum, we stick to. We believe in our voting methods. So how are we doing, Alexa? Are we getting results?
We sure are. We're
Okay,
almost about to close it.
We're not
So
taking
get your
Okay.
votes in.
mail-in, so.
Yeah, we're not accepting mail-in votes, I'm afraid.
All right, Rick, I'm about to close the poll.
Rudy Giuliani's been watching the polls.
Here we go.
Okay, so here we go. So it's very interesting. Before, when we asked afterwards, of course, that first poll that we asked was a little flawed because it asked, what have you done? Not what would you do? What have you done? Well, of course, there are a lot of people that have done transrectal. I did transrectal 16, 17 years ago. But when we asked people, what would you do now? 23% said they would do a transrectal. And now, after listening to you guys discussing, it's down to 22%. The transperineal in the past, 43% said they would choose it after they heard the initial presentations. And now that's gone up to 48%. And the unsure is down to 30. Now, I'm not sure I really want to call a winner in this Oxford style debate, I'll tell you. And one of the reasons is because I have a feeling that Dr. Deborah and Dr. Arvin might have worked side by side at one point in time at Michigan, because I saw that Dr. Deborah did a fellowship at Michigan that finished in 2019. Dr. Arvin, when did you arrive at Michigan?
Ooh, it could be late 2016. There may have been some overlap there.
There may have been some others that. So that fellowship, you guys might have been side by side. So if I declare a winner right now, I may stick an oar between a strong relationship that exists, you know?
It goes long, it goes way further back than that, our
That
relationship.
is
Oh,
true.
does
That is
it?
true.
Since I
Oh,
was, you know,
does it? Well, I've got a couple of questions along those way further back, especially for Dr. George. So maybe you'll join us for a couple of minutes in the room afterwards, so I can ask Dr. George. I just want to say this was a really, really informative debate, and it was conducted with tremendous grace by both of you. And there were some wonderful questions. And I just hope I get to meet both of you in person so we can talk more about this. I'm not really sure who should win. I think I'll ask Howard. After having heard what we've heard today, Howard, have you softened any towards transrectal biopsies?
I have the really greatest respect for Dr. Kaye, but hell no. I think transperineal won the day. And I think we should share this information with the AUA, and I suspect that some of us will be reviewing those guidelines next year. So, but I thought it was well played. And Deborah, I think you came into the lion's den. So I hope it was fair.
Not only do I want to say that for Dr. Deborah, that she came into the lion's den, I would say the greatest question that I heard from anybody, and I will say most of the work that I do with prostate cancer is advanced and recurrent. I don't do a lot of work in this space, but everybody said to me, who can we find to defend transrectals? And I think Dr. Deborah deserves a t-shirt just for being willing to defend transrectals. And so we definitely are going to get you a t-shirt, Dr. Deborah. Alexa will find out what color you want. And I think we can stretch to sending one to Dr. Arvin on the basis of the final poll. So with that said, thank you, everybody. Thanks for sticking around. And we'll be getting back to you with the recording on this so you can watch again and take in some more. Thanks a lot. And
if the doctors and the moderators would check the chat window so you know where we're going to meet. We're going to meet over on GoToMeeting. So you'll see the link there. You can use that to go directly.
And Joe, I'm so sorry to interrupt, but Rick, we want to give a big thank you to our sponsors.
well, we mentioned that before, and I do, of course, want to thank the sponsors. But Alexa, you did such a wonderful job. We should also say that for those listening, ANCAN is not providing medical advice. The doctors may be, but we're not providing medical advice. So it's really up to you to decide what you want to do and to be knowledgeable to ask your urologist the right questions. If the urologist comes in and says, this is what we're going to do, our job is to make sure you know the right question to ask the doctor so that you're comfortable too. That's all we want to do. Okay.
Exactly.
Good night, everybody.
Night.
Good night. Good night.